Dinelli. I'm a third year here at the University of South Alabama. Today I'm going to be presenting on a case of posterior reversible encephalopathy syndrome with bilateral suprachoroidal hemorrhage. So this is a pretty rare case, the first of very few. I'm going to also cover a little bit of a discussion on hypertensive brainstem encephalopathy, also known as HBE, as part of the differential. And this case is going to highlight the complexity of diagnosing hypertensive emergencies and their associated complications. So for our case, we had a 28-year-old woman with no significant past medical history who was found in her jail cell with seizure-like activity. She was taken to the hospital and her blood pressure was found to be critically high at 216/134. She displayed altered mentation and also had complaints of partial blindness. We did initial lab results on her, and that showed severe hyponatremia, some hypoalbuminemia, as well as hypokalemia. We also did a UDS, and that was negative. So we performed a CT scan, which showed no hemorrhage, but did reveal diffuse hypoattenuation of the brainstem. We also did an MRI that revealed T2 flare hyperintensities in the cerebellum, occipital lobe, temporal lobe, and then also the brainstem, but the most severe changes were in the brainstem. The MRI also showed T1 isointense and T2 bright hemorrhages along the posterior medial and lateral ocular walls, which raised concerns for choroidal hemorrhages. Due to these findings, we consulted ophthalmology. Ophthalmology then diagnosed the patient with suprachoroidal hemorrhages, as well as grade 4 papilledema. The patient's clinical presentation was initially concerning for HBE due to brainstem involvement, but we ultimately diagnosed them with PRES. So this was based mostly on imaging findings, which was more consistent with PRES than HBE. So our steps for managing her, so we controlled her blood pressure. Once we did that, her altered mentation returned back to baseline. We watched her, and then we performed a follow-up scan 2 weeks later that showed persistent, but also improved flare signals and a reduction in the size of the suprachoroidal hemorrhages. So at this point, the patient reported improved, although still mildly blurry vision. So for the discussion, I wanted to talk a bit about the way that HBE can present sort of similar to PRES and the critical distinction, because this will guide patient management and also avoid unnecessary interventions. So for PRES, posterior reversible encephalopathy syndrome, so it's thought to result from failure of cerebral autoregulation in response to acute hypertension. And this leads to endothelial dysfunction, which can cause vasogenic edema, particularly in the posterior aspects of the brain. So this will clinically present as seizures, headaches, visual disturbances, altered mentations, and then focal neurologic deficits. These are all sort of things that our patient was exhibiting. For PRES, for treatment, all you really have to do is manage the blood pressure and then address whatever underlying inciting cause was present. And then for hypertensive brainstem encephalopathy, HBE, it's a bit more localized and it tends to be a bit more severe and sustained. It is also a lot less common than PRES. So the symptoms are very similar, tends to focus more on brainstem similar symptoms, such as like ataxia, and then also cranial nerve deficits. It is more challenging to reverse, and it tends to be a bit more focused and rapid. And you also have to make sure that you manage intracranial pressure, whereas for PRES, really you just reduce the blood pressure and address whatever is contributing to it. And then for suprachoroidal hemorrhage, it's rare, but it's serious. And it's usually associated with severe hypertension, as seen in our patient. So the hemorrhage, the pathophysiology behind it is the ciliary arteries rupture due to high arterial pressure that leads to bleeding into the suprachoroidal space. And then this causes sudden onset vision loss, eye pain, headaches, also as seen in our patient. Ultimately, we diagnosed PRES. It is a pretty rare complication of hypertensive crises. For us, ophthalmologic examination was essential in diagnosing the cause of our patient's vision loss, and it's really important to do this because it can lead to permanent blindness if not treated properly and immediately. So sort of to conclude, our case underscores the importance of distinguishing between different types of hypertensive etiologies, such as present HPE. It's important because the management and prognosis of these conditions can differ pretty significantly, and the way that you manage it can really affect the outcome and the clinical course. So being able to differentiate between the imaging findings is what ultimately helped us diagnose PRES as opposed to HPE in our patient. A key takeaway is early identification of hypertensive emergencies and their complications will help you manage and prevent long-term sequelae, such as blindness. And then lastly, for cases of sudden onset visual loss, make sure you consult ophthalmology and do a thorough ophthalmologic examination so that you are able to identify and then treat immediate vision loss, because that could become something that becomes a permanent visual impairment. So this case, I think, has a lot of good multidisciplinary teamwork that ultimately allowed us to help optimize our patient's outcome. Thank you.